right, here we go. Special needs plans. All right. When it comes to special needs plans, there are actually 3 types of special needs plans. We sell 2 of them, the D-SNP and the C-SNP. The I-SNP is the ones for like long-term care and nursing homes, the places like that. They're sold by the carriers, but not through independent agents. So we're going to be concentrating on the D-SNP. And for those who have both Medicare and Medicaid. And we'll talk a little bit about the C-SNP because that one is a really good plan that can be used when you're looking for that SEP. When you've exhausted all the others and you discover that the customer does have some sort of chronic condition. All right. So dual eligible plans, the D-SNP, for those who are enrolled individuals who are entitled to both Medicare, Title 18, and medical assistance from a state under Medicaid, Title 19. States cover some of the Medicare cost depending on the state and the individual's eligibility. Okay? You're going to find that, in the states that are allowed, where the state is allowed the carrier to provide these D-SNP plans, they really bring in some wonderful features that your customers will really like. Care coordination, especially for those who are seeing multiple specialists. They always have that 0 monthly premium. Though it may not appear like that at first, and I'll show you those. Over-the-counter benefits. A lot of plans, that are just MA plans have the over-the-counter benefits. These plans tend to have those like up in the $300 range per quarter, so pretty nice. They have embedded dental, vision, and hearing benefits. I've seen dental benefits as high as $3,000 in some of these plans. Transportation benefits, where the appointments to and from the doctor, pharmacy, that sort of thing. They range from 24 round trips, or 24 one-way trips, per month, which really breaks down to about 1 round trip a month, or unlimited. I've seen that too. Usually you'll see, even on the unlimited, that there is a mileage to this max of around 25 miles. So gym memberships, telehealth was, up until the last couple years when COVID hit, telehealth and then got embedded into almost everything. But at one time that was kind of a real neat thing to have, and it was really popular in the D-SNPs. So by now, you should be pretty knowledgeable on just what's covered by Medicare Parts A and B, and know that there's a 20% cost share associated with Part B. And that cost share is unlimited, right? I mean, the deductible will kick in once a year, but there's no maximum out of pocket when it comes to Part B. And that you must have Part D in order to cover prescription drugs or face a penalty. So if you're new to Medicare, in July we will start our annual review of all things Medicare through our Medicare 101 series in preparation for the 2023, gosh, it's even hard to say that, 2023 AEP, which starts in October. Now, on the other hand, we have Medicaid, and Medicaid provides health coverage to millions of Americans, including, low-income adults, children, pregnant women, elderly adults, people with disabilities. I mean, I think there's kind of a pejorative when we think of Medicaid, but it's out there to help what we would typically referred to as the needy. So Medicaid is determined by each state according to some federal requirements and guidelines. The program is funded jointly by the states and the federal government. Like I said, it was authorized by Title 19 of the Social Security Act, so that Medicaid was actually signed into law in 1965 along with Medicare. They kind of came together. All states, the District of Columbia, and U.S. territories have Medicaid programs. And these are designed, to provide health coverage for low-income people. Although the federal government provides certain parameters that all the plans must follow, each state administers their own Medicaid program differently. This kind of results in variations of Medicaid across the country. The actual administration is done right down at the county level. Okay? So if anybody's ever looking for Medicaid, it's going to be handled by an office with a name like Health and Human Services, provided in each county. Now, today we're talking in broad, general terms about Medicaid. And if you did have some state-specific questions about getting on Medicaid, or what are the requirements in a specific state, this website can help you with that information. So take a screenshot or write that down. And it's just a really good reference for anything or any questions that people could have about what's required in a particular state to get on Medicaid. Unlike the low income subsidy, the extra help program that we talked about last month, we don't generally go out and try to enroll people into Medicaid. Now, when you do the extra help, when you run across those individuals, doing that application will cause it to be sent to the state unless you specify not to, and could help with that enrollment into Medicaid. But like I said, in general, we're not out there trying to get people enrolled in Medicaid. So just try to keep these two programs separate in your mind. Medicare is the only health insurance once a person turns 65, unless they remain covered under an employer-based plan. Medicaid is a state-controlled plan and can go by many different names depending on the state. Okay. I live in Oregon. Here it's called the Oregon Health Plan. Down in California, they call it Medi-Cal. North of me in Washington, it's Apple Health. As we move across the country, we'd see quite a different number of names. Let's see, TennCare in Tennessee, Access in Arizona, Sunshine Health in Florida. It's Medicaid in Alabama. Just be sure that you kind of understand that Medicaid is operated in each state, not federal, and is run under different names in different states, making some amount of confusion understandable. And the two systems do not coordinate. So that's an important thing to keep in mind. There is no coordination between Medicare and Medicaid. Now, according to the Kaiser Family Foundation, and this was from back in October of 2019, right as COVID was starting to hit. So I am sure that that has probably kicked these numbers up even more. But I always call your attention to that bottom one there. 1 in 5 Medicare recipients is on Medicaid. So let's try to look at some numbers of that. There's 63 million people, currently on Medicare, and so 1 in 5, or 20%. That's about 13 million that are going to be, on Medicaid. So there's a lot of people out there. And this map kind of shows a little bit about how dispersed it is. And I know that we spend a lot of time talking blue state, red state kind of stuff, as far as, when it comes to like a short-term plan. Most blue states don't have anything that we can sell that would go over 90 days or so, where the red states, you could put somebody in there and indefinitely, even though it's short term. I mean, you can run them up to 3 years, on what we would call a short term plan. Notice that when it comes to Medicare, Medicaid, we don't see that, right? I mean, we get into the bluest of the blue, California, New York. I mean, that's in Minnesota. These are the traditionally really blue states. But look at Arizona, Florida, Tennessee. These are some really typically red states and are big in the world of Medicare, Medicaid. So Texas, look at that. Anyway, there's so many out there. So this is something that is in every state. And so we should definitely be familiar with it and have some ideas on how to sell it. These are some terms that you're going to see associated with Medicare. With Medicaid. Now, when a Medicaid recipient first gets their letter from Medicaid, it tells them what they are using these terms that we see here, and that it goes into what level of coverage that they're going to receive. So this refers to the various levels of help from Medicaid. Now the terms can vary slightly from state to state, and as an agent you need to know specifically their level of Medicaid in order to fully assist them in plan selection. Yeah, I'm going to tell you that the only statuses that really provide, true dual benefits are just a couple here, okay? The qualified Medicare beneficiary and the full benefit dual eligible. I think that's the same term in a different state, okay? So, for example, in Florida, we may see full benefit dual eligible, where in, say, Texas or California or Oregon, we see qualified Medicare beneficiary. Okay, now I'll break down exactly what they're getting, but just know that the only ones that are getting full Medicaid medical benefits are the ones that say plus, right? And that's 2 of them. Qualified Medicare beneficiary with full Medicaid, QMB plus, and specified low-income Medicare beneficiary with full Medicaid, SLMB plus. Those are the only 2 that really give you the full cost sharing. Although we're going to see that qualified Medicare beneficiary and full benefit dual eligible will probably get full cost sharing also. All the others can be something less than that. I mean, it could be simply all they're getting is their Part B premium paid by the state. Okay. Now, the good news is regardless of their level of benefit, they have the SEP to do an enrollment virtually every quarter of the year, right? It's a little bit different in the third quarter, and we'll talk about that some more here in a moment. just for now, just know that there's all these different terms, and the ones that we have to really look out for are going to be ones with the spin down, because they are definitely not getting the full Medicaid benefits. They're just, have some level of help, and then the with the spin down, we'll go into that here in a little bit more detail. So in order to go into Medicaid, you need to be down there, the individuals at poverty level. Okay, they're pretty needy. And Medicare or Medicaid uses the term categorically needy, meaning that they don't have enough money to provide for all the services that they need. Now there's another group that due to their medical cost, so it's kind of an optional Medicaid eligibility group, and this is kind of going to be made up of individuals who qualify for coverage because of high medical expenses. Okay? So these individuals meet Medicaid's categorical requirements of medically needy. So they have all these high medical bills that push them over. They could be making too much money, or they could be having too high of assets to qualify under the categorically needy. So they fall under this group called medically needy. And they don't have to offer the same package to them as they offer the categorically needy. So what we're going to see in these Medicaid categories, whose income is above the specified amount, that would normally disqualify an individual from Medicaid. However, because they've been categorized as medically needy, they may qualify for Medicaid coverage even though their countable incomes are higher than the specified amounts, by coming up with this spin down. Now, under this process, the medical expenses that the individual incurs, during a specified amount of time, and that happens to be monthly, they're going to be deducted from their income during that period. And so once it's been reduced to whatever that state specified level is, then they're going to qualify for Medicaid benefits for the remainder of that period. Okay? And that period is going to be the remainder of the month. All right, so now that was a lot of legal mumbo jumbo. I've seen the calculation that they do. It's pretty convoluted, where they analyze their medical expenses and they look at their income and they come up with this number. Okay? I've seen these spin downs ranging from $100 as high as $1,000 a month. So what we'll do here is I'm going to give you a kind of an example, very simplified, but it just kind of trying to get the point home for you. So my individual is a family of one, and his income is around $1,573 a month, just to keep the numbers easy. So you can see that to be at 100% of poverty level, my individual at $1,573 makes about $500 a month too much money to fall under that categorically needy, right? But he's been determined to be medically needy. So what's happened here is that means that he's got to deplete $500 worth of income on his medical expenses before the state will kick in. So for my example, the individual's on dialysis, remembering that dialysis is one of those dreaded diseases that can put you onto Medicaid regardless of age, into Medicare regardless of age. So Medicare was going to pay about 80% of the cost. and the individual's got to pay that 20%. Well, a dialysis treatment typically costs about $500. So with Medicare paying $400 of it, 20%, it's going to leave our poor person here $100 having to pay for that treatment that time. So as you can see that with a $500 spend down, the individual is going to pay for the first 5 treatments each month, and at which point he'll have met the spend down requirement, and Medicaid will kick in and pay the remaining $700 a month, plus any other medical bills that were to arise, because at that point, once he's paid that $500, he is on full Medicaid for the remainder of the month. So, and then the next month, it starts all over again. So I always look at it, the easiest way to really get a grip on this is to look at it this way. We all know how a deductible works, right? You have your medical deductible on just about any other, insurance plan, but it's annual, right? But the company doesn't pay until you've met the deductible. So with a spend down, each month I have to meet my spend down, my deductible for the month, and then the insurance will pay. And in that case, it's Medicaid. So that's kind of how that spend down would factor in there. Like I said, the good news, they have an SEP. So we're going to be able to help them out. So just try to keep this straight. The following is going to describe the various categories of individuals who are collectively known as dual eligible. Okay? So they could be receiving the full amount, or they could just be getting something from the Medicare Savings Program. Like I said, all they're doing is paying their Part B premium. So it can be any of those. The only requirement is that they're getting some form of Medicaid benefit. So this chart kind of shows what those are. So if you get full Medicaid only, so that's typically not somebody on Medicare, you see that they would literally pay for everything. They're a medically needy status, special income level, institutionalized. Medicaid would pay for Part A or Part B premiums, cost sharing. They would pay everything in there. Okay, so if you're QMB only, okay, that's a qualified Medicare beneficiary. You look at what the benefit is that they would pay. I mean, first of all, your income is 100% or less than federal poverty level. Okay? And there's some asset stuff there, your resources. But the benefit that they get is Medicaid would pay Part A if they had it, if they had to pay it. Okay, Part B, they would pay, Medicare's deductible, Medicare's co-insurance up to the Part B, and any co-payment they had, and everything be paid for that goes with their Medicare, right? So if Medicare covered it, then their level of Medicaid covers it. So remember, Medicaid doesn't cover, Medicare doesn't cover a lot of things that Medicaid does. So if they're QMB only, they are only going to get Medicaid to pay for the things that Medicare pays for. So then we have the QMB plus. So now we get not just the QMB stuff, but we also get full Medicaid benefits. So it could be everything from hearing aids to dentures. I mean, whatever it is that they needed is now going to be covered under Medicaid. So we'll see that as we look at the other ones, like SLMB, remember, so now they could be making more money. Okay, they're still poor, don't get me wrong, 100 but less than 120% of federal poverty level. So Medicaid is now just going to be paying their Part B premium. Okay, that's all. But if they've got the plus, they still get the full Medicaid coverage. But all these others are just have different requirements. There's different income requirements, different resource requirements. But you see that they're pretty much limited to just getting their Part A and Part B premiums paid. And that's usually about all that they're going to get without the plus designation. So we talked about who qualifies for the D-SNP, okay? Well, one of the things that you're going to find is that we're really going to have to dive into the plan itself to see what level of cost sharing the individual is going to have. And I can tell you that for sure, the people with the plus will have all their cost sharing covered. It's whoever else, we're going to have to get into that summary of benefits and take a look to see what they're going to get. And so now, as far as when you can sell it, there is no set enrollment period. And these customers can actually change what they have each quarter. Okay? So you're going to need to follow up with them, make sure that they're using their plan and that somebody else doesn't just come along and sell them a bill of goods and takes them out of your plan and puts them into a different plan, because that can happen and does pretty frequently. Most of the plans will protect you as agent of record if they try to put them in the same plan that you did, but if they try to switch them out into a different company's plan, you can lose them as a customer. So I always try to tell people you really want to stay in contact with these people and make sure you have a good program for keeping in contact and making sure that they stay happy with their plan, because they can change for the first 3 quarters of the year, pretty much at any time. The way it would work is like if you made that change here in February, it would start in March. It's going to just literally start the following month, even though they're limited on when they could make the next change again. They couldn't make another change in March to start in April, because that would be 2 changes in a quarter. But it's typically will start the first of the next month until we get to the 4th quarter. And the 4th quarter is going to follow AEP rules. In other words, if I enroll in October, it's not going to start in November. It's going to start on 1 January. So just remember how that works. So let's take a look at a couple of summary plan descriptions, and we will see exactly kind of how these work here. And what I was telling you is what you got to look for. So this is a United Healthcare Dual Complete HMO plan. It's a D-SNP. And so we'll kind of dive in here. And it tells me that in this plan, you have to fall into one of these Medicaid categories. So QMB plus, QMB, qualified disabled working individual, qualified individual, specified. Look at this. These are all the categories, okay, that we've gone over. So all you had to be to enroll in this plan was on Medicaid. And of course you get the service area. Now what would have driven you to this plan would have been when you got in and put in the zip code, and they would have had to have resided in one of these counties for this plan to have shown up as even being available. But what I like to draw your attention to is we get down here into the plan. Remember I told you that the plan premiums were 0? That's because this is covering the drug portion, and the drug portion is going to be covered under extra help. So the plan premium to the individual will in fact be 0. But look at this cost sharing. It said that they would accept all of those different categories. However, It says if you have full Medicaid, remember that had to be a plus on your designation, or a qualified Medicare beneficiary, you'll pay $0 for your Medicare covered services as noted in the cost sharing chart. So what is the cost sharing for somebody that's just SLMB? I don't know, okay, because it doesn't tell me. It looks like, it could be as much as like $65 here or $90 for the emergency room visit. Could be 20% on some of these tests. I mean, I don't know what their service level is going to be. I just know what those three are going to be. So even though that it says that all those are available, I'd just be careful with that. So look at this, $2,500 on dental coverage. So that could be enough for somebody, that is maybe SLMB, but has big dental needs, but doesn't have a high medical needs to want to get into this plan. Okay? So that's what I'm pointing out, is that while the cost sharing can be a little bit of a mystery, who knows? $400 for eyewear. Criminy, that's incredible. Let's see, what do they get here for their over the counter? Let's find that one. So fitness, 105 a month on a prepaid card. Nice, right? So they can get some groceries and on healthy food. I mean, this is a pretty terrific plan for somebody who maybe doesn't fall into the category that gets everything paid for, because they don't meet all of this, but some of the other needs could drive them in there, and it would still be a good plan for them. Okay. So then we'll take a look at this one. This is another one from United, but it's a PPO plan. Okay, and in this one, it's telling you just QMB plus, QMB, and SLMB plus. Okay, if you don't fall into one of those categories, you can't even enroll in the plan. And this one serves the entire state of Texas. Okay, so you see how you got to get into these and see exactly what's in there. Okay, this one is a Humana's plan in Jacksonville, Florida. So it's in these counties of Florida. And when it comes to who qualifies, find that to be eligible. It's got the standard eligibility statement of entitled to Part A and enrolled in Part B, live in the service area, and receive some level of assistance from Florida Medicaid. And then down here, it goes on to tell you that you have to be SLMB plus, QMB plus, or full benefit dual eligible, FBDE. So those are the only ones that would even be eligible to enroll. All right, so now, what do you do if the state doesn't have a Medicaid plan? Okay, you're on Medicaid, but they don't have a D-SNP plan, excuse me. So we're going to show them an MA plan. That's going to be the plan in there. But we're going to have to be careful with this because remember, the plans don't coordinate. So I need to make sure that whoever their doctor is, because if they were seeing a doctor on Medicaid, that was a Medicaid doctor. But is that doctor in the network? Because if they're not, I can cause them to have a copay. Okay? So I want to make sure that that I don't do that to them, because I'm going to show them a regular MA plan. So seeing that doctor may have a copay associated in the MA plan. So I need to make sure it's a Medicaid doctor so that Medicaid would cover it, because we're going to show both cards. We're going to show the card for the plan We're going to show our Medicaid card. We'll talk specifically about this MMAI opt-out for the states that have that. Okay? So we need to make sure that our beneficiary is on Medicaid. And so we'll talk a little bit about how we do that. I told you that they got that letter at the very beginning, and they probably still don't have it or know what their level of service is. So this is what you're going to need. You're going to need their zip code, their Medicare number, their last name and suffix if it has one, junior, senior, the third kind of stuff, Part A effective dates, and their date of birth. Now, some carriers are going to require you to call in to the carrier and verify the eligibility, and others are going to want you to use their online tools. So if you're going to call in, you're going to have to have collected that information, and you're going to tell it to the carrier. But I think more and more they're moving to this online method. And so here we see, this is a picture from Anthem, where you would click here and you would go into the verification process. I had recently done one through United, and so I went ahead and copied over that one. So you put in the state, the zip code, the county, remember it's down at the county level, their name, date of birth, when the plan's supposed to go effective, and if you had their Medicaid number, you could put it in, or you can put in their Medicare number. In this case, I had the Medicare number, and I didn't realize that when I copied this, and so I had to blank it out. Get their permission, and then hit this button here where it says check Medicaid eligibility. And then it'll go through, and this is kind of what came back when I did Linda here. So we see Linda, her name, it gives me her Medicaid number if I didn't have it already. Remember that many of the forms are going to need that. Okay? They're going to want to know that. This is maintaining dual LIS SEP availability, yes. I'm not sure why it said LIS for proposed date. It says no. I don't know why it did that, but it did. But then it comes down here and tells me that in my area here, United Medicare Assure PPO plan. Notice that's not a SNP, okay? That is just an MA plan. And then as far as Medicaid status, it says customer has active Medicaid, but the level is not available. Ask the enrollee questions to determine if they experience any cost share with Medicaid. So in this case, I said, I'm talking to Linda. I said, Linda, when you go to the doctor, do you have to pay anything? And she says, no. How about any specialists? No, I don't have to pay anything there either. Have you been hospitalized? And she says, yes, I was in the hospital. Did you have any portion of that bill that you had to pay? No. Yep, it was all. When you get your medications, do you pay anything for that? Because remember, she was turning 65 and going on to Medicare and Medicaid at the same time. So I'm asking, because under Medicaid, if you get full Medicaid, you don't pay for medications. So she tells me she didn't pay anything. So at that point, I have to explain to her what's going to happen with prescription drugs when she goes into Medicare, because what was once paid for by the state no longer is being paid for by the state. So she'll have to have some little bit of a copay, and she's going to have extra help, so that'll help out too. Let's see how it said the Assure program. Okay, so there are some states that I told you earlier that Medicare and Medicaid do not coordinate. Well, that's for most intents and purposes, that's true. But in Illinois, they did do a little project called MMAI, so the Medicare-Medicaid Alignment Initiative. And if you lived in the greater Chicago area or a few counties of central Illinois, it covered about 15 counties in general of the 100 and some counties in Illinois. So it was just a demonstration project. But in this area, the county and Medicaid did coordinate and did work together for this test plan. Now, so it's just there in Illinois. Prior to COVID hitting, and we were looking at, there was another 8 states that were starting to look at doing this, and that was Arizona, California, Idaho, Massachusetts, Minnesota, New Jersey, New York, and Wisconsin. They were getting ready to look into this. Then, COVID hit, and all of that stuff got put on hold. So right now, the only area that has that is the central Illinois and the Chicagoland area. And if they do have, are in that area, you can still enroll them in a plan. However, they have to formally opt out. Because what will happen is if they go and don't do that, you can enroll them in the plan and it'll look like everything goes through, and then the state will flip it and it'll go back to the MMAI. So we just want to make sure that they actually do the opt-out process. Okay. So I'm also going to take a quick look at the Assure benefit. This is the one for here in Oregon where I live. And what you'll find is this plan, the $40.50 would be covered by extra help. And it says Medicare cost sharing. Again, if you have full Medicaid benefits or QMB, you'd have 0 cost sharing. So it's going to look a whole lot like an a dual plan, but it's not. It is actually simply an MA plan that has all these other benefits tacked into it. So anybody can enroll in it, but if they fall under these types, these 3 categories, all their cost sharing is 0 in the plan. So it works out pretty good for those who do have this situation. Okay. All right, so we talked last month about LIS. I just really wanted you to know that all the people on Medicaid have LIS. It's just one of the processes that they'll do is enroll them. And if they lose their Medicaid, remember that the plans don't coordinate, and the LIS will usually remain in effect until at least the end of the year, at which time they would have to requalify. And maybe they qualify for LIS and not Medicaid, because that's pretty common. Okay. These are some resources to assist you. The first one there is for LIS, their Social Security's phone number. Refer people to the County Health and Human Services office if they're looking for Medicaid. And again, if you want to try to help answer any questions, there's that website that I showed you earlier. So any questions on D-SNPs, just use the chat and I'd be glad to answer any questions. Okay. So far, I'm not seeing anything, so I'm just going to move right along to C-SNPs. Okay, so we're going to look at the C-SNP. And one of the reasons we usually get into these plans is because the person has contacted you. They've got a problem. Something has happened. Maybe they got a new prescription that wasn't in their formulary. They're being referred to a doctor who's not in their plan. They've just got some kind of a problem. And here's one of the really common ones. They moved, but they didn't do their filing on time, and so now they're been kicked off whatever MA plan they were on from before and are on straight Medicare. And and with that, they lost their drug plan, all at one time because they didn't take action when they should have. So they've come to you. There's, you've asked all those questions. Did you move? They did, but they weren't in the time frame anymore. They don't get Medicaid. They don't get extra help. So you've just started asking all these questions, and you find out that perhaps they have some kind of severe chronic condition. So these plans are designed to restrict the enrollment to individuals with one of these severe chronic conditions. And you think, well, who could those people be? How can there be that many out there? Well, again, going back to the Kaiser Family Foundation, they found out that about 2/3 of the Medicare enrollees have multiple chronic conditions requiring some coordination among primary care providers and specialists. So many of them are going to meet this. They just don't know that they have this opportunity out there. So here's the 15 conditions. I am not trying to tell you that all 15 of these plans are going to be available in every county of the country. Quite the opposite. I would tell you that number 4, 5, 7, and 12. Those are the really common C-SNPs that we find out there, for heart problems, diabetes, and lung issues like COPD. And while the others are there in some places, typically they're going to be a pretty large, metropolitan area that would have that. But you just don't, find them everywhere. So what we do is we ask the questions, and if they fall into one of these, when we're checking for what plans are available where they live, we're going to try to see if there's any of these plans there. Now, if you go to Medicare.gov, it's one of the filters on there that you can assign to say, I want to see the C-SNP and D-SNP plans, and it'll show you, what's available there. And if you're using mostly companies like, the big ones for this, I'd say Anthem is probably the biggest. They seem to have the most from my experience. Followed by, if I go to United's quoting, where I'm looking at just United plans, you can put in the zip code and you can say special needs plans and see it that way there. Humana just seems to throw them right there on the website together, as does Aetna. They're not going to take your word for it or your customer's word for it. They're going to want to verify the condition. This sample letter I'm showing you here is from Humana. It would be just like that, very similar from any of the other carriers. Most of these are going to want this letter before the plan goes into effect. I think there's a couple of them that may let it go into effect, on short notice, like here we are, on the 23rd, and I need a plan to start on Tuesday the 1st of next month. They may hold up until they get the document, or they may give you until the end of March to provide the document. They're usually pretty thing about it is that without it, they will definitely terminate the plan, or it may not even start. So let me show you just a couple of these. And here's one here. This is from Anthem. And you can see that this is a lung care and a heart care. And you're going to find out this is in Clark County, Nevada. But They do quite a bit. Where did I go? I saw it there. Okay, so here's the thing. You have to be the standard Part A, Part B, live in the service area. But they say you can have diabetes, chronic lung or cardiovascular disorder, or chronic heart failure. So it's all ors in there in order to enroll in this plan. So it's kind of, those are the top 4 that I was telling you anyway, right? So they've got one plan that just throws them all in there, right? Cardiovascular, heart, lung, and diabetes. And I do believe you'll see it's a 0 premium. Yep, okay, 0 premium. Okay, and they always include drug plans. It's always going to have a Part D associated with it. And the thing about these are, they typically, if you're in like a diabetes plan, you're going to have more endocrinologists and more diabetes related drugs in the formulary. So they've really kind of tailored the plan for those people. This is the Humana one, okay? Again, entitled to Part A, enrolled in Part B, diagnosed with diabetes and live in the service area. I think this one is probably Jacksonville. Yep, the Jacksonville area and these counties. So the big benefit, and like I said, is the thing that drives you to these plans in most cases is going to be you're just trying to find something that would be there to let you do the enrollment. You can do that enrollment once each quarter, once per year in the C-SNP, right? D-SNP once a quarter, C-SNP once per year. So as long as they have the qualifying condition, you can enroll them in the plan. Okay, you can hit me with any questions that you have. I usually like to make sure that you know to be able to contact me, and you can contact me at training at AHCPsales.com. So if you have any questions or would want a copy of the presentation, just hit me with an email and I will gladly answer your questions or provide you a copy. Not seeing any questions, I am just going to go ahead and shut it down and hope you have a great day. I always like to let you know next month the training will be on Medigap plans. And we'll talk about typically what plans we do sell and what are the advantage of those plans. And we'll look a little bit at Massachusetts, Minnesota, and Wisconsin, who have plans that are a bit different than everybody else.